Hello, and happy Tuesday, I think. Welcome. I am really excited to talk about functional neurologic disorders tonight and to answer your questions. So I got a great question sent to me by a physical therapist who has been working on a whole FND program, which is amazing. And it's a very common question. So I was just like, we got to talk about this. So first of all, if we haven't met, my name is Julie Hirschberg. I'm a neurologic physical therapist. I'm based in the Los Angeles area. I'm the founder, owner of Reactive Therapy and Wellness. And I love to join you all live here on our Instagram, hear from you, get your questions, talk about cases, all of the things. And this particular question was sent by one of our Brain Bites members. So I do a lot of mentoring and teaching with other clinicians, physical therapists, occupational therapists, psychologists, speech therapists, and so on. And so this was sent by a fellow member. I'm going to read you the question here. So one question this person said that has been a theme among a couple of participants in their program is helping them understand how our different interventions that temporarily reduce symptoms like walking with weights, which is very helpful for a lot of symptoms, by the way. Walking with weights to reduce upper extremity tremor will eventually not be needed as frequently to mitigate functional symptoms. I was curious if you'd be able to, I'm sorry, I'm having such a hard time reading this. If you would be willing to provide insight into, number one, how do you begin to wean or reduce use of external cues and sensory tricks as patients move through the program? And have you found an explanation useful when patients ask similar questions? So this is a brilliant question. Number one, let's talk about the treatment, and then we can talk about the progression. So this person has done our complex case masterclass, has done a lot of our Brain Bite sessions. So they know and understand that treatment in functional neurologic disorders is wide ranging, and it includes a lot of different pieces we use our pie chart. So that includes motor control, that includes addressing the sensory system, that includes the autonomic nervous system, that includes lifestyle interventions and addressing the psychosocial needs for the person. And it also involves addressing the physical impairments. So what I hear a lot from folks is like, great, I can get started. I can assess those pieces and I can get started down one of the paths. And not very unusual to then be asked, now how do I progress to the next thing? This is really common, not just in functional neurologic disorders, but honestly, everything in neuro rehab. What's the next step of progression? And so I want to clear up a couple of pieces for this particular question, because I think it really helps with the progression. So number one is the idea of having sensory tricks. So this term comes actually from dystonia treatment. If a person has idiopathic dystonia, they may have a particular sensory cue on their body that they might call a trick that helps control the dystonia. So a really common one for cervical dystonia is like touching their chin or cheek or neck or hand on the head. Those would be called a sensory trick. That is not something that is really applicable to functional neurologic disorders. I would say the term trick is kind of a misnomer, and it's just not a term that I use in functional neurologic disorders. Now, sensory training, 100%. So let's distinguish those. When I think of having somebody use weighting, for example, I always think about why might weighting be helpful for this person? And that depends on my assessment. So if my assessment determines that there is otolith dysfunction. So that's the part of the vestibular system that senses change in gravity or graviception and our perception of upright. Is if there is a abnormality in that system, weighting can be helpful. Or maybe there is actually a proprioceptive deficit or kinesthetic deficit, a sensory mapping deficit of that person's body. Then I might use weighting. I might use tape. I might use different objects with that person around their joint or around their body part. I might use some type of bracing for them because of the sensory deficit. So the number one thing is, what is the underlying difference for that person? And if we find that something is helpful, like adding weights for them or adding some other sort of object or doing sensory training, we're going to do that for the purpose of retraining the sensory system. So it's not a trick, it's a train. It is training. We are looking to improve either their sensory integration or improve the map of their sensory system. So I shared this picture in a post today. So if I'm going to pull it up on my iPad here. So if you can't see it well during this, you can go back to the post. It is this image here, and I just don't think the iPad shows up super clearly, but maybe you can see that. So this here, this picture, this is the sensory homunculus, and I'll just grab the brain model here too. So in the brain, towards the back part of the brain, we have the sensory map of our body. This shows us where all of our limbs are in space. It shows us our mouth, our face, like literally everything. There's a map of it here. And what this picture shows, this picture is was in a published article. Let me pull up it was from 2016, actually, PT article, which was about manual therapy and neuroscience education in pain. And there's a lot of overlap in these concepts for many disorders. But what they included here in these pictures was at the top, around the low back, that sensory map is smudged. There's not a clear representation of the back. Now, this is in that study, but I would say when I'm testing somebody with functional neurologic disorder and they're having, it could be anything. It could be a sensory symptom like a numbness, but it could be something like tremor or myoclonus or dystonia or weakness. Often we will see a similar smudging of the sensory map, meaning that person does not know precisely where that part of their body is in space. And in fact, this is so common. I'll give you an example. Natalie, one of our therapists, was testing somebody the other day and doing this on their leg. And when she would touch the knee, she thought it was the ankle. When she touched the hip, she thought it was the calf. That tells you that sensory map is not accurate. And then we want to train it, right? So we do all kinds of different types of training to basically reconfigure that sensory map and make it more distinct. So what I would say in response to this question, that's not a trick. It is actually sensory training that we're doing. And as that map improves and the person has more practice then with more regular movement, they get better. And it does happen over time. And for some people, it takes a little bit longer than others. But I have generally found that when we can find the deficit and really target it, we change people's maps. And like in this particular study and many others, this has not been done in functional neurologic disorders, but it has been done in chronic pain. And there is a lot of overlap when it comes to the brain changes. And a lot of folks that I see with functional neurologic disorders also have pain. And so these principles apply. Some of the actual protocols for the sensory treatment take about a 10-week approach. And I have seen people do 10 weeks in like 3 weeks sometimes. So they can progress really quickly through some of the sensory discrimination training, and therefore don't need those extra sensory pieces because they know where their limb is in space. So for example, if somebody like in this question has upper extremity tremor and weighting is helpful, I'm guessing the weighting is helpful because it gives more proprioceptive input. And as that person then remaps their sensory map, they're not going to need the weight. Now, sometimes that is actually like you're starting with a heavy weight and you decrease the weight and decrease the weight and decrease the weight, decrease how much time the weight is needed, and the person gets better. So to the second part of the question, so I wouldn't even call that weaning or gradually reducing it. It really is just training, just like we would train any other system, just like we would train with any other person with a neurologic disorder. Now, sometimes we find that as we go through and we're adding some of the sensory pieces to training, it's not quite enough for the person, and they need different pieces of sensory information, and that's okay too. That's not really a step backwards. It just means the deficit that they have is different. So for example, if you often, I think weighting and adding weights can be really helpful for a lot of people, but then of course I've met folks where that's not helpful at all. So that doesn't mean that sensory training, you should throw it out the window. It just means they might need a different type of sensory training. Maybe it's more movement related, vestibular related. Maybe it's light touch related. Maybe vibration would be more helpful. And again, if it's helpful in the moment, it means you are training the sensory system. It doesn't mean that you're tricking the sensory system. You are training it, and it's going to get better. So the explanation then that I use with people is exactly that. We're training your system, and it's going to get better. It gets better with training. If we don't figure it out right away, so let's say we try something, it doesn't work, happens a lot in physical therapy and occupational therapy. Try something, it doesn't work. It doesn't mean that system doesn't need training. Again, it just means we need to find the right thing to train with. Usually the right modality. And maybe it's actually layering on other pieces. So again, when it comes to progression, it may be if a person has a very dysregulated nervous system, we may have to start with some autonomic training. And then we can add on some of the sensory pieces of the pie, or then we can add on motor control. So that would be another way to progress training. And it might be this little ebb and flow that, wow, that person did really well with weighting. We're starting to see better movement. We take away the weight and the tremor is back. Okay, let's see if we can actually add in an autonomic piece, because we know that tremor can also be related to the autonomic nervous system. Now, of course, we need to assess this, but let's assess it, let's treat that, and let's see if actually together, between addressing the autonomic nervous system and the sensory system, that we can actually start to progress and change the weighting and change the sensory map with a more regulated nervous system. That's probably the number one thing that I hear from people is like, oh, well, I can't really do motor control training because they have so much tremor and myoclonus that they can't even support themselves. And so we might need that nervous system regulation piece first, and then we can move on. And I'm just making sure I'm not missing anybody's questions or comments. So by the way, you can put questions, comments in the chat here as we're going. Now, somebody asked specifically, how might this look for cervical dystonia? Now, idiopathic cervical dystonia is not a functional neurologic disorder. It is a totally separate disorder. Now, a person with idiopathic cervical dystonia may also have functional dystonia. That could occur. You'd want to assess that and treat that. But a person with a functional neurologic disorder could also have functional cervical dystonia. It's very different from idiopathic cervical dystonia in that it's more variable. And let's say, for example, this person doesn't experience their dystonia symptoms if we put on a weighted vest. Now, I, of course, would want to know, why did we put on that weighted vest? So was there a sensory deficit in the trunk? So was there maybe a proprioceptive deficit? We test this a lot with using a joint position error, using a laser on the trunk or the neck. So I'd want to test that and then treat it. Now, sometimes we might use a weighted vest because of otolith dysfunction, or sometimes we might use a weighted vest because of a dysautonomia. So the why behind the weighted vest would be really important. And certainly there are things that a person may have. Let's say they had an underlying polyneuropathy and a sensory ataxia, and with profound sensory loss. Well, that person might need the weighted vest for a very long time. They have less opportunity to change that sensory map because of a severe sensory polyneuropathy. Now, that's not typically what we're talking about when it comes to FND, but we need to test that and understand, is there a neuropathy underlying this? It's usually not the case in FND, but I'm a firm believer in testing things out. So back to the case of a functional cervical dystonia, if we were to find, let's say that person's symptoms got a lot better with a weighted vest, fabulous. I might then actually have that person use the weighted vest to go do more activities that they enjoy. So it might help them drive a car, for example. It might help them go out for a walk. It might help them go to their son's baseball game. So can they use the weighted vest to start doing more activities that they love? And doing activities, including exercise, including movement, they're all regulatory to the nervous system. And so in that way, using the weighted vest is going to actually allow that person to do more things to improve the control of their movement. And then what I'm going to do is I'm going to keep checking it, right? So let's come back, next visit. Let's try things with and without the weighted vest. Let's see if they have improved their proprioceptive awareness of their body. Let's actually retest it to see if it's better. And if it is, then maybe they need less weight. Maybe they don't even need the weighted vest. Maybe they just need a weighted neck wrap. Maybe they just need a weighted headband. We could progress that in many different ways because it got better, because we tested it in the first place and we saw the baseline. This is what I love about joint proprioception error testing, is that it's a very objective test. We can test it, we can treat, we can come back and test it again. So in the case, again, of a functional cervical dystonia, we might go back and retest it. Okay, now they don't need the weighted vest, but they're still getting occasions where their neck motor control is impaired and they don't have voluntary control over it. Let's see, are there other pieces of the sensory system we need to address? So what is their sensory discrimination around their neck? I'm going to test it. I'm going to treat it. And there's actually a really great protocol of progressing sensory discrimination training on any body part. So we might go through progressing that training and we'll keep retesting it until they have a better map of their neck in their sensory homunculus, right? So in that way, we can progress sensory training. Same for motor control. So another thing that was kind of implied by this question was an external cue or external focus. So let's say a person with neck functional movement difficulties actually does really well with an external focus. So let's say they have the laser on their headlamp, and when that laser is directed at a target and they're tracing things, they have great control. But as soon as that laser is off, it's gone, right? So that's not a trick, that's an external focus. That's a motor control treatment technique to allow somebody to have automatic movement. We do better with external focus, and automatic movement really becomes unmasked in that setting. So that automatic movement though is going to start getting trained with that external focus. So we're going to do repetitions there, and then we're going to try it without. We may go from the laser headlamp to something else. Maybe we'll use a noodle on the head. In fact, the more silly, the better, in my opinion. But that's just kind of me. I like the silly thing. So a noodle on the head, maybe it's a hat, and they're looking at the brim of the hat. A person might need a lot of external focus to improve. But they will not need it forever. I guarantee it, because I see it all of the time. As the person improves their abilities, they need less and less external focus. And that is because the brain is literally relearning the movement strategy through the external focus. This is the same for athletes who are relearning a move. It takes some repetition and practice, and often they do better with external focus, by the way, and then they go into the game and they're able to do it. Now, for the person with a functional neurologic disorder, what is really helpful is that they're back in the game, back in life, back doing activities that they love, and they have more opportunities for automatic activities because they're doing the things that they love. And so there's a nice ability for carryover into activities when you're doing activities. So we pair the progression with a person really getting back to those things they want to do, the things that they love, because it gives an opportunity for automatic practice. And maybe initially they need an external focus or cue to do them, but after they do them more and more, they don't need it, just like an athlete. And I know it can seem like when a person starts and they're like, well, this is great, but that's because I have tape on the floor or I'm stepping over an object. How do I do this at home? I hear that all of the time. It can seem almost impossible that it gets better, but it absolutely gets better because we get back. You make those small incremental improvements and you get back to life, which is very automatic when it comes to movement. Life is set up like one big external focus, and that really helps us reintegrate and relearn those movement patterns. And so in short to this question, it is, the brain is relearning. And when people ask it, I will say, you know what, you're gonna have to trust me on this. Your brain will relearn this pattern. It might take some repetition, but it's going to learn it. Okay, I got some questions. I also should have brought some water, but I have my decaf cappuccino here. I talked a lot there. Okay, Taylor says, I have a patient exactly like that. Does great with external focus and distraction, but we're getting stuck. His symptoms always come back when he tries to relax. Okay, Taylor, what a great insight. And this is something also that we see. Sometimes when a person actually stops moving and starts relaxing, they can get their symptoms, sometimes worse. Now, this is where I love working with our OT, working with our psychology team to understand what are those sensory needs of the person. Sometimes the person is a person that is wired in a way that needs movement. So our team does the sensory profile. We look at that. What are their vestibular and proprioceptive needs? And this person may actually need more movement to help re-regulate their nervous system and not to help with this kind of brain-changing process. Now, there can be many other reasons why a person struggles to relax and the symptoms come back, right? And it's really, really complex. I'm just going to give a personal example because in the past, I struggled relaxing. I'm kind of a go, go, go person. I love movement. My brain is kind of go, go, go. And some of that's anxiety driven. And I've been in a lot of therapy. I recognize that I actually struggled to sit down and stop, and it made me even more anxious. And now I have found, lots and lots of years of therapy later, I have found that, hey, I actually need some heavy work and heavy activity like lifting weights, like running, and it helps regulate my nervous system so that I can sit down and relax. I also need support for some of the racing thoughts, and this is psychological support for racing thoughts and those feelings of inadequacy that make me kind of need to go, go, go. And you know what? I've learned to be able to sit down and relax and not have to constantly move my body. And that is, I'm not saying that that's everybody's, but I think when we see that, we want to look holistically at the person. And I think working with OT, understanding that person's sensory profile, understanding with psychology as well, could be a really important piece. What a great question. Now, the other thing, Taylor, I would say is, can that person also keep progressing the activity and life that they're involved in? Not meaning that they don't ever relax, but maybe relaxation looks different for them. Maybe they are rocking in a hammock. Maybe they are reading a book or swaying to music. So maybe to start out with at least an externally focused relaxation or kind of wind down would be really helpful. I love working with our OTs. They're really great at working on kind of wake up routines and wind down routines with people and getting to what that person's nervous system really needs. What a brilliant question. Alicia asks, any thoughts of severe fear of falling with FND and history of falls? Any specific suggestions? I feel like, Alicia, we should do a whole nother live on falls. I'm going to even write this down because it's a great question and I think we should talk about. But just briefly here, this is where some of the same principles that we would use with anybody who is falling would apply here. I want to understand the why. Lots of sensory organization pieces go into that in FND, just like in any other neurologic disorder. I want to understand why they're falling. And of course, they have fear of falling because they fell. That is like 100% of the folks that I see, regardless of the diagnosis of falling, you get that fear of falling and you can get a real cycle because that fear response really can drive rigidity. It can drive abnormal postural responses, and that person is set up to fall, right? And so what I typically see in a person with FND is the sensory organization is impaired. So again, I look at what is their sensory awareness of their body, and can I give them some things that help improve that and therefore build their confidence to do more activities and to experience success. This is where sensory training could be really helpful. Maybe this person, it's the weighted vest. The thing I love about the weighted vest, it's not like magical by any means, but I have one myself. For some people, myself included, it almost feels like a hug. It's like security. So it could be really helpful. But hold that thought, because I think this is great. Can I like screenshot this? Yes, I can, because Alicia, I want to come back to your question and do a whole segment on falls and fear of falling. It's so good. Okay, then somebody said, I have FND. My legs are paralyzed and my upper arms also. I'm 24 hours in bed. My therapist giving me relax exercises and catalepsy, but it doesn't really work. I live in the Netherlands. Well, first of all, thank you for joining us from the Netherlands, because we're not on the same time zone at all. And also, I'm sorry this is happening for you. It is just devastating to not have control of your legs and arms, to be in bed, and not be able to move. It's very hard for me on an Instagram live, though, to give very specific things that would be helpful for you. I haven't assessed you. I have no idea if this is happening because of autonomic dysfunction, for example, which is something I see really commonly, just like a nervous system shutdown with dysautonomia. And that would be, so a piece of advice I would say is to ask it sounds like you're getting therapy. So to ask your therapist to test out your autonomic nervous system, your sensory system, and see if there's a deficiency there. My guess is there is, and would be treatable. Relaxation exercises on a whole are not the treatment for FND. For some people, they can be one part of the treatment, but particularly for a person who is weak and paralyzed, relaxation is actually not the thing that we need. We might actually need movement in a very safe way. So I'm sorry I can't be more specific. I can't really provide medical consultations during my live videos, but I would absolutely give advice of what to ask your therapist. So if you're a person with FND, you absolutely should ask your therapist about assessing and treating the autonomic and the sensory parts of your nervous system. And this person also says, what can I do? I want my life back. Absolutely. I want your life back for you. And I will tell you, because we work with folks like you who are so weak and in bed, and that itself brings secondary issues. And when I want to, tell you and encourage you is that's not the end all. People can get better. Sometimes it takes a long time, particularly for a person that is fully paralyzed. So I don't want you to give up hope, even if you don't see progress right away. Sometimes people are expecting, even therapists, I will tell you, might expect a person with FND to get better in one session. I had another therapist tell me this, that somebody asked her, you mean people don't get better in one session? No, they don't. You have to really assess and get down to the underlying pieces, and it might take a long time to figure those out. And some people do, like in that initial evaluation, already start to notice changes because you're addressing some of the underlying issues. But that is certainly not always the case. And Alicia's commenting sensory training for sure, doing weights in the hands, whole body vibration, love it. I wish I had contacts in the Netherlands. I do not, and I wish I did. If I did, I would absolutely contact you and let you know. And if anybody else does who's on these videos and can comment on any great referrals in the Netherlands, that would be really helpful for this person. So that's it. Great questions as always. Thank you for joining me today for this discussion about FND treatment progression based on really great questions that physical therapists send me. So appreciate the questions and appreciate you for being here and for listening. I am going to, every week I put these videos in a newsletter. I include the references for the articles that I talk about, and I will put this in this week's newsletter. I have a Friday newsletter that goes out for clinicians. You can sign up on reactiveeducation.com. And if you're a patient, sign up on reactivept.com. That way you won't get all of the stuff that we send to therapists, but you'll get something very specific to you. If you're a person with FND, by the way, we are hosting our very first it's not an exercise class. It's one of our wellness program classes. We have a wellness program for people with neurologic disorders. We have in-person and online classes. We're having our very first FND specific class, and it starts next week on Monday. It's on Monday evenings at 5:00 p.m. It's led by our psychologist, and it's a brain-body class, getting the brain and the body to talk to each other. And you can check it out. It's at reactivept.com/recenter. And honestly, if you're a therapist that wants to get a patient connected to a class like this, go send this their way at reactivept.com/recenter. It's a brand new class. It's going to be every week on Monday nights, and we'll record it as well. And it's going to be awesome. We've been talking about this for a long time. This is our first class. So if you'd like to join us and you have FND, or if you have a patient with FND, this is led by our team, and it's called Recenter. It's at reactivept.com/recenter. I see a couple more questions here. So what do you suggest therapists should be looking for? Because I have seen multiple and they tell me there's no underlying issues. But then I have the doctors tell me it must be psychological. They can't help me either. First of all, this is Amanda. It's so frustrating. And I'm so sorry that you're coming up against that. It is true that we could have underlying psychological pieces. I don't want to ignore that. But I am the first person to tell you that I don't believe it's entirely psychological, and we must dive a little deeper. So when I say assessments, I'm not meaning lab tests or MRIs or EMGs or things like that. I'm talking about clinical assessments that physical therapists and occupational therapists can do. So I mentioned the sensory profile. The sensory system is often overlooked. It's not just, can you feel this, but it's, what is the map of your body? So we do sensory discrimination testing. That's something like 2-point discrimination testing. We've got norms, objective norms for this type of testing. Many people don't do it, and they absolutely should. So 2-point discrimination testing, sensory grid testing, which looks at the map of the body, stereognosis testing, graphesthesia testing, proprioceptive testing, like the joint position error. Amanda, I don't know what's happening for you, but I think just diving into that next layer and asking your therapist to watch our videos, you can send this video to them and ask them to dive a little deeper into the sensory system. For the autonomic nervous system, we test it with heart rate variability. You could do it on your Apple Watch. It's not super reliable. We use a portable EKG called the Leaf. It's not expensive. We use it in the clinic. People can use polar heart rate monitors. So we test heart rate variability, and then we look for dysautonomia. We look for orthostatic intolerance. We look for POTS. We don't diagnose those things, but we can screen them. And it's all done with heart rate and blood pressure, really standard things that people can be looking at, but sometimes they don't or don't realize it. I mean, in all honesty, I would say maybe 10 years ago, I wasn't realizing that those were things that I could be testing and doing. So when you know better, you do better. So those are the things that I would specifically ask about. And if there are psychosocial factors that are contributing to symptoms, I really advocate for people to get that support and get the support from somebody that really understands chronic health conditions and functional neurologic disorders. And Amanda, you might try out our class. It's really about those activities that help in brain-body connection. Some pieces are mindfulness, some are sensory, some are autonomic. It's not a pure kind of mindfulness or meditation class, it's all of the pieces. So that could be helpful for you as well. And Amanda shares too, thank you so much. I'm just getting passed around doctor to doctor, so I appreciate it. And that is something that we really commonly hear. Passed around from doctor to doctor, nobody seems to be able to figure it out. And honestly, sometimes, I hate to say this, Amanda, it's our broken healthcare system. It is the doctors or the therapists not taking the time. Maybe they have 15, 20-minute appointments, and these things take a long time. It also takes a long time to hear your whole story and put the pieces together. I would never be able to do that in a 20-minute or 30-minute appointment. And I think it's really unfortunate in our healthcare system that it's set up that way. And I think that means that people get passed around because there's something missing. They didn't get to listen to your whole story. And I gotta tell you, Amanda, when I get to listen to somebody's whole story, when I do a consultation for our programs, I get 45 minutes, maybe an hour, and I get to listen and I get to put the pieces together and I get to ask and probe questions about these other symptoms. It's so eye-opening to me. I know exactly where to go, exactly what they need from a testing perspective so we could test out those symptoms and then be able to move into treatment. And I just think our healthcare system is not set up for that level of listening, particularly when a person, like most people that I see, have a longer history. Maybe they have multiple conditions that are complex and they take a lot of coordination, and our healthcare system is just not set up well for that. And I'm just really sorry that that is the case. And honestly, you could be in other countries and it's similar. I'm not just harping on the US. I think you can find similar things in other countries too. Doctors not talking to each other and figuring it out together. And that's exactly why we do an integrated program here where we're all talking to each other. We set aside that time every week. We are all figuring it out together and working together as a team for a person. So Amanda, I just want to say thank you for sharing that. And I know it's really hard and frustrating. And I hope that you have some more information now to advocate. Not that that should be your job, but at least you have some more information and knowledge to advocate with your team and advocate in Australia. So thank you so much, Amanda, for the comments. And thank you again, all of you, for being here. Continue to send me messages. Continue to ask questions. I learn so much from the questions that you ask, these conversations that we have every week as well. And don't forget, sign up for our newsletter. If you're a clinician, reactiveeducation.com. I'll send the whole video. I'll send links to the articles, reactivept.com if you're a patient. And if you're a person with a functional neurologic disorder, we have our brand new class starting next week called Recenter, and you can sign up at reactivept.com/recenter. Thanks so much for being here, everybody, and I will see you soon.